All right, today we're putting you directly in the hot seat for what might be one of the toughest tests in medicine, the final oral exam to become a consultant surgeon. We're talking years of training, your entire career on the line, all boiling down to just a few crucial minutes.
So, just imagine it. You're the candidate. The examiners are sitting right across the table from you. In a moment, they're going to give you a case, a real-life scenario that's designed to test everything, not just what you know, but your judgment, your nerve, and your ability to make life-or-death decisions when the pressure is on. Seriously, your whole career is hanging in the balance.
And just like that, the exam begins. The very first challenge is always to wrap your head around the clinical problem they've just thrown at you. Your time starts now. Okay, so I'm going to be playing both roles here for you. As the examiner, my job is to push, to challenge, to make sure you're safe to practice. And this opening question? It's intentionally broad. It's really designed to see how you think on your feet, how you structure your entire approach from the get-go.
Now, as the candidate, my response has to be calm, collected, and totally structured. I'd start by saying my approach is to take a focused history and then do a physical exam. The key facts are jumping out at me. A 65-year-old guy with sudden 10 out of 10 abdominal pain. I mean, alarm bells are just blaring. And his risk factors are absolutely critical. He's a long-term smoker, and he has atrial fibrillation. That's an irregular heartbeat that's notorious for forming blood clots. But, and this is huge, he's not taking his medication for it. This history is basically screaming vascular problem.
So here it is, the absolute linchpin of the physical exam. The patient is telling you he's in the worst pain of his entire life. But when you examine his abdomen, it's soft. There's no guarding, no rigidity, nothing. This disconnect, what we call pain out of proportion to clinical signs, is the classic textbook description of a catastrophe. You cannot miss this clue.
The examiner sees I've picked up on those key signs. So naturally, the next question is, can I put all the pieces of the puzzle together? They're testing my clinical reasoning right now.
A really good candidate doesn't just rattle off a list, they prioritize it. So I would say my leading differential diagnosis, without a doubt, is acute mesenteric ischemia. And I'd back that up. It's because of the sudden, severe pain, the fact that the pain is way out of proportion to the exam, and his huge risk factor of non-compliant atrial fibrillation, which can throw clots straight into the gut's arteries. Of course, I'd mention other possibilities like severe gastritis or even a heart attack presenting as belly pain, but honestly, they just don't fit the picture nearly as well.
Okay, so I've got a pretty strong hunch about the diagnosis. But in surgery, you can never, ever act on just a hunch. You have to prove it, and you have to do it fast. Every single minute counts here.
So now the examiner is testing my plan of action. What tests do I actually need? And maybe more importantly, what's the order of priority? I have to confirm what I think is going on and get ready to intervene.
The examiner then gives me the blood results. The white blood cell count is a little high, which is a sign of stress. But the real story, the one that tells you something is terribly wrong, is in the blood gas. It shows the body is in a state of severe metabolic acidosis. Basically, the blood has become way too acidic. You can see the pH is low at 7.30 and the lactic acid is high at 3. That is a massive red flag. As the candidate, I have to jump on this immediately. These results show a severe metabolic acidosis with a raised lactate. And what does that actually mean? It means tissue is dying. When the gut loses its blood supply, it flips to this emergency backup metabolism that pumps out tons of lactic acid. This is the biochemical signature of ischemia, and it's telling me in no uncertain terms that this patient is critically ill. Now, the blood tests are pretty damning, but the gold standard, the test that's going to give us the definitive answer, is a CT angiogram. This is a special kind of CT scan where we inject dye into the arteries to light them up and see the blood flow. And in this case, it confirms everything. The scan shows a filling defect. Yep, that's the clot, stuck right in the superior mesenteric artery, which is the main highway for blood to the small bowel. We have our diagnosis.
With that diagnosis locked in, the examiner wants a management plan stat. I'd lay it out systematically. First, admit the patient and make them nil per os, that's nothing by mouth, to give the bowel a rest. Then we start aggressive IV fluids and broad-spectrum antibiotics because a dying gut can leak nasty bacteria. And critically, I'd start an IV heparin drip to stop that clot from getting any bigger and immediately prepare the patient for an emergency operation. This shows a safe, urgent, and logical plan.
So, let's fast forward to the operating room. This is where surgical skill, and more importantly, surgical judgment, are truly put to the test. Believe me, the easy part is over. Now, we have to face the consequences of this disease head-on.
The scene is grim. We've opened the abdomen, and a massive section of the small bowel is just black. It's necrotic. It's completely dead. This is pretty much the worst-case scenario. The ischemia was severe, and it went on for too long. The only thing you can do is resect. You have to cut out all of that dead intestine.
Okay, so I've just removed meters of dead bowel, but now the patient is crashing right there on the table. His blood pressure is plummeting, his heart is racing, and the anesthetist is yelling at me that his acidosis is getting even worse. This is a full-blown physiological crisis, and it's being driven by the massive inflammatory storm that the dead gut has unleashed on his body.
And this is the moment of truth in the entire exam. The examiner literally leans in. They've just thrown a massive curveball. The patient is actively dying on your operating table. Answering this one question correctly is what separates a pass from a fail. This isn't about textbook knowledge anymore. It's about pure life-saving judgment.
The correct answer here isn't some fancy, complicated surgical technique. It's a concept. It's a whole philosophy, really. Damage control surgery. So as the candidate, I have to make my decision crystal clear. I'd say, at this point, my priority is not definitive reconstruction, it is patient survival. Trying to join the bowel ends back together, a primary anastomosis, in a patient this unstable with this much acidosis is incredibly high risk. That joint would almost certainly leak. The right move here is damage control surgery. And I'd explain, this means we cut the operation short, we staple off the bowel ends, maybe do a temporary closure, and get the patient to the ICU as fast as humanly possible so he can be resuscitated. We have to fight the physiological war first, and we'll deal with the anatomical battle later.
The examiner would then probably ask, okay, so when will you operate again? And the answer is a critical part of the whole damage control plan. I'd say, I will plan for a second look laparotomy in 24 to 48 hours. This buys the ICU team precious time to fix the acidosis and stabilize the patient, and it gives us a chance to go back and see how the remaining bowel is doing. And guess what? The strategy worked. The patient was stabilized in the ICU. Now it's time to head back to the operating room and finally finish the job.
So we go back in 48 hours later, and the picture is completely different. The patient is stable. The remaining bowel that looked kind of iffy before is now pink and healthy. Now, and only now, is it safe to perform the anastomosis and join the small bowel back together. This just shows you the incredible power of that damage control approach.
So the patient's life has been saved, but the exam isn't just about managing one case correctly. It's really about demonstrating the core principles that will make you a safe, competent consultant surgeon.
So why did this candidate pass? Well, first, they had a structured approach right from the very beginning. Second, and this is huge, they always put patient safety first, choosing damage control over a flashy but risky anastomosis. Third, their communication was clear and confident. They explained their reasoning every step of the way. And finally, a great candidate is always thinking one step ahead.
Because just when you think it's over, just when you think you can relax, the examiner will hit you with another question, often a deep dive into the basic science behind it all. You've handled the case well. Now, explain to me the cellular mechanisms of reperfusion injury that happen after you restore blood flow to that ischemic bowel. And that, right there, is the nature of the surgical hot seat. You always have to be ready for what comes next.